Thank you for joining this webinar on animal health challenges in pastoralist areas. My name is Koen van Troos and I work for the Belgian NGO Vets Without Borders, Vétérinaires sans Frontières, and I'm the Education and Policy Manager. We, with VSF Belgium, have been focal point of the coalition of European lobbies for Eastern African pastoralism since 2013. Now, as you know, with CELEP, we focus on lobbying advocacy, knowledge management, and communication on pastoralism in Eastern Africa, which is also the reason why we are organizing this series of webinars. We started the webinar series a few weeks ago with a very interesting session on understanding pastoralism and the use of words when we talk about pastoralism. Now, the second edition was on participatory rangeland management in Kenya and Tanzania and offered some interesting lessons and insights on issues related to rangeland management and land tenure. Summaries of these webinars will become available on the CELEP website in the weeks to come. Also this webinar, by the way. And so here we are today in our third webinar, which is co-organized by our members Concern and my employer VSF Belgium. The webinar will focus on animal health challenges in pastoralist areas and will end at around 2:30, which is 4:30 in Eastern Africa. Now we have three interesting speakers lined up. So one is already visible. It's my colleague, Dr. Emmanuel Emaruk, who is our country representative for VSF Belgium in Uganda. And his presentation, he will inform us on how VSF-B is implementing the One Health approach in Karamoja, Uganda. And next we will have Hassan Olow, who works for Concern Worldwide. Voila, there's Hassan. And he's based in Kenya. His presentation is entitled Animal Health Systems Strengthened Through the E-voucher Model, and it will highlight Concern Worldwide experiences in Marsabit County in Kenya. Now, after each presentation, we will have a series of Q&A. So there will be one presentation, then the possibility to ask questions, then the other presentation, and again, the possibility to ask questions. Now, if you want to ask a question, you can use the Q&A function in Zoom, which is a possibility to ask written questions. Another possibility is also for you to raise your hand. And if you raise your hand, we can give you the floor and you can actually exchange directly with the speakers who take part in this webinar today. As you can see, the chat function is also active, and we actually encourage attendees to introduce themselves in the chat and say who they are and to which structure they belong, which organization, to improve also interactivity in these confined times. So I think this is more or less clear. Now, without further ado, I'll give the floor to Dr. Emaruk. So, dear Emmanuel, the floor is yours. So please, you can start the presentation. Thank you.
Thank you, Koen. Once again, I'm Dr. Emmanuel Emaruk, and I work for VSF Belgium in Karamoja, Uganda. I'm going to make a presentation on providing quality animal health services in Karamoja, but also through a community One Health approach. So as you can see there, is the photo of Karamoja sub-region. And one of the community animal health workers is the one on the photo.
Emmanuel, I think you can change the slide yourself.
Yes, I'm trying to do that, but my slide is not moving. Ah, okay, finally.
There it is.
Okay, so the next screen that you see there is where we work. We're in Africa, and in Africa it is in Uganda. And in Uganda, we are talking about Karamoja sub-region. That is the red place on the map that you see there. And specifically in Karamoja, we are looking at 3 districts. That is Kabong, Larenga, and then Moroto. Yes, so again, in terms of the operational area, but also an highlight on the context of Karamoja. We are talking of an area covering 10,800 square kilometers, which has a population of 1.2 million people. Over 70% of the people live in the rural areas, and the major livelihood options practiced pastoralism and agro-pastoralism. Of course, there is some subsistence crop agriculture, which is mainly rain-fed. Still to continue the context, like I mentioned, the main live sources are crop and livestock. So Karamoja sub-region holds 2.3 million cattle, which comprises 19.8% of the cattle population in Uganda, about 1.7 million sheep, which is almost 50% of the population, and then 2 million goats. Karamoja sub-region also has almost all the donkey population in Uganda at 91.3%. So Karamoja sub-region is part of the Karamoja cluster, consisting mainly of agro-pastoralist groups. Livestock is highly mobile. They move in search of pasture and water. And therefore, this creates challenges in terms of post-delivery. In terms of the actual cost of delivery of services, but also distances moved in order to deliver these services. Yes, like I mentioned at the beginning of the presentation, we are talking about the One Health approach. But what is exactly One Health? One Health is an approach that aims to promote human, animal, and environmental health through multidisciplinary and multi-sectoral collaborations. It recognizes intrinsic relationships between animal diseases, public health, and ecosystem transformation. So to do that, we have to address these issues in a holistic manner and in a systemic way in order to achieve long-lasting results in terms of health, universal health. So you can get more on One Health approach on our website. That is the link that you can see below there. So we've already talked about the One Health approach, but why a One Health approach? As you may be aware, the world population is growing, and this has led to increase the intensity of interactions between humans, animals, and the ecosystem. Because of this increased intensity of interactions, we are having more zoonotic diseases. Some are emerging and re-emerging. For example, in Uganda, we've had hemorrhagic fevers as the result of encroachment of people in forests. Examples include Marburg disease, Ebola, and others. There are also issues of food safety arising still from consumption of animal products, but also contamination of food sources. Antimicrobial resistance is an emerging thing because of the treatments that we do on livestock. And if withdrawal periods are not respected, you have this antimicrobial resistance also coming in people. Economic well-being is a prime factor, especially if you are looking at public health. What we've seen is that communities that have low economic well-being also have difficulties in terms of addressing their sanitation and hygiene challenges. Of course, if you have poor sanitation and hygiene, then food and nutrition also becomes a problem, especially for children who are under 5 years of age due to malnutrition. Now, we can look at specifically in our area of implementation, which is Karamoja sub-region. There have been some risk factors that we have identified through the course of implementation of our projects, one of which was implementing One Health at a community level. We've seen a relatively high prevalence of zoonotic diseases, and these include brucellosis, rabies, tuberculosis, and trypanosomiasis. People are sharing shelter and water with livestock. This is both because of the insufficient access to water, especially in the kraals. Karamoja sub-region hosts one of the national parks in Uganda. Over the last decade, we have seen an increased density of tsetse flies within the neighboring areas of the park. The pastoralists use dogs a lot as guard animals, and we've also seen an increased population of stray dogs leading to periodic outbreaks of rabies. Unregulated cross-border trades is a very pertinent factor in terms of risks, especially when we talk about Rift Valley fever. We also have a relatively high prevalence of foodborne diseases. I talked about sanitation and hygiene before, which is actually poor around the manyatas. And some of these diseases include salmonellosis, cholera, colibacillosis, hepatitis E, and worms. In areas where the pigs are many, especially in Karenga, there is high incidence of worms in pigs, but also in humans. Hepatitis E has been identified as a risk factor in progression of hepatitis B, and therefore we're also seeing more mortalities in people due to hepatitis B. The other risk factors include consumption of poorly cooked meat and raw meat and blood, which affects high prevalence of foodborne diseases. Poor sanitation practices, hand washing basically, and then poor latrine coverage, which leads to open defecation. Yes, we have environmental degradation because of poor latrine coverage and usage, and then leads, because people are defecating outside, when we have heavy rains, it contaminates the water sources, including the shallow wells and the aquifers for some boreholes. We also have issues of misuse of antibiotics. As you may have seen at the beginning of the presentation, the area is vast, and the delivery of veterinary services is low. And we are having people treating the livestock themselves. And then when these livestock die, they don't respect the withdrawal periods. And you have issues of misuse of antibiotics and antimicrobial resistance. So how have we approached the One Health approach in Karamoja? We have had 2 entry points. One is at the community level, and then the other one is looking at the livestock themselves. So the 2 approaches, we have had 4 axes of implementation. The first axis is to increase veterinary services to the pastoralist communities. The second axis is to increase community awareness, especially the connection between human and animal health, and in particular, the risk factors that we've identified can lead to zoonotic diseases in the community. We've had community engagement, and this includes surveillance on zoonotic diseases, and increased access to clean water and sanitation for communities. And we are looking at the Manyata level, but also within the kraals to increase access to livestock and separation of watering areas for livestock and humans. So I'm going to talk a little bit in detail about that. Increased access to vet services. We've been able to achieve increased access to community-based animal health services through training and capacity building of community animal workers. Specific One Health interventions, and these include vaccination of dogs against rabies, disease surveillance on zoonotic diseases, and screening of goats for brucellosis. Some of the results for that have been over 2,000 dogs vaccinated against rabies. The communities are more satisfied with the level with the cow services, leading to an increase of up to over 70%. And we've used the death rate of goats as an indicator of the health services. And we have seen a decrease in the death rate of goats from 15% to 10%. Still, we've gone ahead to increase community awareness on the One Health risk factors. And what we have done is community dialogue meetings for identification of risk factors on One Health. We've implemented joint outreach with human NGOs. For this one, what we discovered is that, especially in the crowds and in the dry season, when even the children have migrated together with the cattle, there is a population of children who are not reached in the crowds. When you combine a human and veterinary outreach, you have higher numbers of livestock turning out, but also a higher number of people turning out for vaccination program. And then, of course, we've trained the community animal workers and village health teams and wildlife rangers on diseases of One Health significance. This has helped to increase awareness, but also to improve surveillance. And then promotion of community-led total sanitation and hygiene at Manyata level. This is an approach which involves communities to recognize the sanitation and hygiene issues that they have, leading to construction of latrines, but also to implementation of sanitation practices like hand washing. Yes, like I mentioned in the earlier slide, following training of the village health teams and community animal workers, we're able to have now disease surveillance at the community level. But also we've involved the public health, health teams and veterinary authorities in participatory disease search. This data has been collected, analyzed, and transmitted to the higher authorities, especially at the national level. Part of that led to recognition of Sese problem in Karamoja, which now led the government to intervene. On increased access to water and sanitation, we've provided rehabilitation actions on water points, but also construction of cattle traps, which has decreased contamination of the aquifers. Over the course of implementation, we realized that the VSLA approach has been very good in terms of increasing cohesion, but also leveraging the approach for implementation of water user committees and sanitation practices within the communities. Those are some of the results that we obtained from increased access to water and sanitation. Latrine usage increased from 37 to 78.7%. The functionality of water points increased from 58.5 to 78%. And latrine coverage increased from 36.5 to 70%. So through the Community One Health project, we were able to document the challenges at the community level. And then these challenges were transmitted to the national level, especially the SESE control point. At first, they were saying, no, SESE flies cannot be there a lot in Karamoja. And from our actions, they're able to recognize that. This led to SESE control in Karamoja, leading to over 50,000 livestock sprayed with acaricides, and a subsequent reduction in tick-borne diseases within the project area. Of course, now, as you're aware, we've had COVID. Initially, during the project, it has been very difficult to have collaborative approach between the different disciplines. But when COVID came, there has been a lot of interaction between the public health, veterinary authorities, and human health. We now have task forces at the national level, but also at the district level. So this shows how, for example, collaborative approach can be used to manage diseases effectively. In terms of the lessons learned, what we realized that limited accessibility to finances and logistics, this includes fuel, vehicles, and motorbikes, limit rapid investigation of suspected disease outbreaks. Of course, there is a limited coordination of the stakeholders required for a good One Health intervention. And for example, it took the emergence of COVID for this to be realized, and how we hope this can continue post the COVID era. As I mentioned before, VSLs are actually very good in terms of leveraging and creating cohesion for continuity of the sanitation and hygiene practices within the communities. So we've come to the end of the presentation, and we thank you all for attending. Thank you.
Thank you very much, Emmanuel, for this interesting presentation. I already see a lot of questions are actually coming up, both in the chat and in the Q&A. May I please ask all of you to consider the Q&A option to ask questions, because otherwise it becomes a bit difficult for us to handle all of the questions. I also saw at one point that there were some hands that were raised, but they're no longer up. So I think we can, Emmanuel, if you agree, we can go through some of the questions that were asked in the Q&A box. So one is that, and I quote, under the One Health approach, have there been any changes to pasture, fodder, water, and or rangelands management? Yeah, so that's one question.
Could you come again?
Actually, you can see it yourself as well, Emmanuel. If you click on Q&A, you can see the different questions that were asked there. So the first question is, under the One Health approach, have there been any changes to pasture, fodder, water, and or rangelands management? Then there's a very particular question regarding the Rift Valley fever virus. The question is whether it is a problem or not in the region of Uganda. There is a question also about the connection, the interrelation between VSLA groups to WASH. So what is the connection between both of them? And then there's also another question about what the suspected route of infection is of hepatitis E, and what is the main source and route of these infections? Is it human-to-human infection via polluted water? Another question is about the village health teams. Are they an NGO intervention or a government structure? And then there's another question also about a number of activities related to human and animal health. Could you highlight those activities that you consider addressing environmental health? So this, I think, relates more to the taking into account of the environmental health component as part of the One Health approach. I don't know, Emmanuel, it's up to you to decide. Perhaps we can already start with this series of questions, and then you could already start answering them.
Okay, I can start with the Rift Valley fever. Over the past 5 years, Uganda has been able to detect antibodies of Rift Valley fever in livestock. The same happened also with PPR. We started detecting PPR antibodies prior to the disease outbreak. Yes, so there has been one confirmed outbreak of Rift Valley fever in Kabale, Uganda. So regarding hepatitis B is transmitted through the orophycal route. Actually, at one time in Gabon.
Sorry, Emmanuel, you're saying hepatitis B, but the question is hepatitis E.
E.
Yes.
E.
Yeah.
Hepatitis B is transmitted through the orophycal route. It's different from hepatitis B, which is transmitted through body fluids and blood. So there's a difference between the two. However, it has been documented that hepatitis E, let me say, combined infection by hepatitis E and B leads to a rapid progression of hepatitis B, which is more lethal and dangerous to humans. So in terms of the rangelands, I did not want to bring in the aspect of rangelands to this presentation. Yes, but under a different project, we supported what we commonly now call the rangeland management committees. And these are people who have been trained on land use planning and rangeland management. On behalf of the communities, they have been able to implement rotational grazing, but also preservation of certain pastures for use in the dry season. And then this is where the aspect of water comes in. When you do water point rehabilitation or construction in pastoral areas, yes, you're also looking at rangeland management because you're promoting mobility instead of livestock or crowding in one maybe big water source. The relationship between WASH and VSLA. The approach that we used was to anchor the WASH interventions on the VSLA. So for example, under the WASH interventions, we had village health teams, we had water user committees, we had the village health teams, the water user committees, pump attendants, all coming up and forming a VSLA group. So in essence, because the VSLA group meets on a weekly basis, these people can now discuss other interventions which are now related to WASH. For example, in terms of latrine construction, every week after the VSLA group, they all go together and start constructing latrines. The VSLA group also provided a platform through which a small fee could be collected for maintenance of the borehole. Or if the fee is exhausted, the communities could also get their own VSLA savings and use to rehabilitate the boreholes and then recover the money later through borehole fees. Is there anything that I've missed? I think environment component, yes. When you're talking about opendification, and you're having about 40 households in one manyatta. Often, if they don't have latrines, they will go outside the manyatta. So you find all around the manyatta has a lot of feces. So when it rains, this of course is washed off, and then this pollutes the surrounding water sources. Aside from that, this fecal matter around the villages is also consumed by livestock. And again, people who are consuming blood or meat which is improperly cooked get infections from this livestock. And that's why you have cases of, for example, cholera coming up when you have high rainfall regime. You have worms in people, especially tapeworms because of the pigs. But you also have coliforms, you have salmonellosis, all arising from poor sanitation and hygiene practices. Thank you.
Thank you, Emmanuel. There was one question also that that you didn't answer yet, I think, or otherwise I missed it. Are the village health teams an NGO intervention, or are they a government structure? So who puts them in?
Yes, village health teams initially started as NGO interventions, but have now been included within the government structure. For example, village health teams in Uganda also receive a kit from government. This includes basic drugs that they can administer to the communities who are very far away from the health centers. So you could say that the very first line of treatment before someone goes to the hospital.
All right, thank you. And then we have 4 more questions. So if you agree, I'll just go through them and then you can answer them. So the first question is, did you face any challenges with water points management committees? So are there any lessons learned from that level? Second question is on, does the government have a structure on health and WASH promotion strategy, like the one that exists in Ethiopia? If that is the case, what is the actual contribution of the project? Then also related to government and development partners have been training a lot of community animal health workers. So are there any guidelines or policy frameworks in place that have been put in place to avoid duplication and only building the capacities of the existing ones to ease sustainability? So very much related to community animal health workers. And another question on how the community is integrated in disease surveillance working. So very much focused on what you presented with the community one health approach. How is the reporting done and how are the trainings done and to whom? And then a final question, is there a cross-border One Health approach planned or in place, as Karamoja is also part of the Karamoja cluster? Is there a lot of mobility and transhumance of pastoralists, for instance, Tukane coming from Kenya into Karamoja and etc. So did you get the questions, Emmanuel? Because they're quite a lot.
Yeah, you've been quite fast, eh?
So the first one, perhaps, on the challenges related to the water point management committees. What are the lessons learned related to that?
Yes, yes, I think I can answer that one. Yes, of course, there have been challenges of water user committees because one of the common challenges has been that once they are trained, that is it. They stop the intervention there. Like I've mentioned again, when we use the VSLA approach, because VSLAs go beyond one cycle. It can go up to 10 cycles until the communities feel that maybe it's not necessary for them. So when you anchor the water user committees to the VSLA, these communities are able to stay for much longer, intervening on issues of access to water. Of course, there is a challenge because in terms of where the capacity of the water user committees ends, they are supposed to do light rehabilitation. If they exceed the certain amount, for example, in Uganda, then it is the role of a district to do the water point repair and maintenance. I think I've talked about that. What was the next question? There was something about government.
Yes, about the government and about the training of community animal health workers. So are there specific guidelines related to that? And how do you build upon the capacity of the existing community animal health workers?
Yes, okay. For Uganda, for example, Karamoja sub-region is the only region where community animal workers are accepted. And the issue of training community animal workers, the NGOs came together under the umbrella of the Karamoja Livestock Development Forum, KLDF. And here, way back in 2007, we all agreed that there should be no more training of community animal workers in Karamoja. So for over the past 10 years, there have not been any new trainings. But still, if you're now talking about the government, there is now what we call the veterinary and para-veterinary bill, which is in Parliament, which now recognizes also other people within the veterinary profession. Initially, there was only the veterinary bill. So people, for example, who did diploma were not recognized. So this creates an opportunity for inclusion of community animal workers. But now in Uganda, we also have the community animal workers curriculum. And this curriculum, for example, stipulates who should be a community animal worker. And one of the things is that they should have some kind of literacy. On cross-border, currently we are not looking at cross-border interventions. But I know, for example, there is a One Health Central and East Africa, which encompasses East and Central Africa. And these people, for example, even provided technical support to the project. I talked about training of the VHTs, cows, and rangers. Part of the training was provided by One Health Central and East Africa. I hope I've answered everything.
No, well, actually, there are two more questions that are pending, but I suggest to answer them afterwards because otherwise we won't have enough time to listen to Hassan. But perhaps, Emmanuel, you can actually answer them in writing through the Q&A box. And if not now, we can answer them later on.
Okay.
Because we have to keep an eye on the time. So thank you so much, Emmanuel, for the answering all of these questions and for your interesting presentation. So right now, I suggest to listen to Hassan Olow. Hassan works for Concern, as earlier mentioned, in Kenya. Concern is developing a program on E-vouchers, so on the E-voucher model, and so Hassan will focus on that in his presentation. So the same goes as for the previous presentation. If you have questions, please ask them to the Q&A box because it's very difficult for us to follow up what is happening in the chat box. So Hassan, the floor is yours. Thank you so much.
Yeah, thank you so much, Kun, and thanks everyone. I hope you can see my presentation. So I'm Hassan Olow, Livelihoods Coordinator at Concern Worldwide, the Kenya program. We were to do this presentation with my colleague, Dr. Tabitha Njeri, who unfortunately is feeling unwell today, but I saw her participating among the participants. So in case of some questions, I think we'll respond to that. The presentation is about animal health system strengthening through the E-voucher model, and this is sharing the experiences of Concern Worldwide in Marsabit County. This is a journey that started in 2017 and still an ongoing journey. The presentation will focus on Concern's program in Marsabit, focus on animal health system strengthening. Then the bulk of the presentation will be around the evolution of the E-voucher model. E-voucher, in this case, being electronic voucher. We'll have the first and second phases. Then we have the legs operational research, the legs that is livestock emergency guidelines and standards. And finally, the third phase and way forward. Concern works in Marsabit. As you can see on the right of the presentation, this is a reflection of Marsabit County, which has 4 sub-counties and 20 wards. It's made up of a number of communities, but the major characteristic is pastoralism and agro-pastoralism as the main livelihood system, where approximately 81% of the population rely directly on livestock for food and income, where the bulk, almost 2/3 of revenue collected by the county government comes from pastoralism-related areas. We also have approximately 2.3 million livestock population, but these are characterized by underutilized economic value in terms of the economic benefit of the owners. We also have a very high dependency on the government and civil society organizations for provision of animal health services and drugs. In this case, Concern works by supporting the most vulnerable population through multi-sectoral development and relief programs. And since the 2010 Constitution introduced devolution, we work in very close collaboration and partnership with the county governments. The key challenges that are there and faced in Marsabit, and the focus of this presentation tries to address, and also the focus of concerns program, is lack of animal health services in remote areas where private animal health services and public animal health services are not necessarily where you see pastoralists and large number of populations. We also have regular notifiable disease outbreaks. We have a very unregulated livestock drugs market. So we have massive presence of counterfeit drugs. And we work in a context where recurrent drought is increasing. The frequency has increased from every 5 years to around every 2 to 3 years. And this has an impact directly on rangelands, where we see rangelands shrinking. And we have also loss of livestock as a result of the recurrent drought, as a result of animal health. And we see more and more pastoralist populations dropping out of pastoralism, but still maintaining the way of life of pastoralism, and gradually moving into extreme poverty. In focusing on the animal health program on system strengthening, what we do in Marsabit, working very closely with the county government, as you can see from these pictures, is enabling and strengthening disease surveillance by supporting the county veterinary department to undertake regular disease surveillance. As you can see, some of it involves actual field level examination or participatory rural appraisal methods with communities to collect information, as well as use of laboratories to ascertain some of those disease strains. And we also support vaccination and treatment campaigns. And essentially, we've been trying to address one key challenge that has been, how do we create a public-private partnership for animal health service delivery, considering that this is a very, very huge gap that has been there, and this has always created the underutilization of the economic value of the livestock population. And through this, we created an E-voucher model that has gone through a number of phases. So the first phase was in 2017-2018, towards the end of the 2016-2017 drought. Through eco funding, we tried to pilot a simple model where we enable pastoralists to access animal health services from private veterinary pharmacists. So this involved targeting 300 most vulnerable pastoralists during the drought emergency period. And it was done through a tripartite agreement where concern working to deliver the subsidy. And we utilized the Hunger Safety Net program, whose payment system was handled by Equity Bank, as well as engaging agrovets. So we topped up a certain amount of money, about $30, to 300 beneficiaries, with the anticipation that this will be utilized and redeemed from 4 agrovets in Northor and Laisami sub-counties through the Hunger Safety Net program ATM cards. One key outstanding lesson was that it really led to a limited restriction on use of the E-voucher, considering this was an ATM card, and beneficiaries could withdraw the money either from the agrovets or from any other, although we saw most of them buying drugs. But then there was also another problem in terms of drugs administration. A number of pastoralists, as you saw in the picture at the top slide, where a pastoralist will administer antibiotics, creating more problems than probably solutions. So it got us really thinking through that this could be a potential model that we can utilize, but there are quite a number of challenges that we are facing. And one of it was the restriction, and the other one was we are violating the Veterinary Professionals and Paraprofessionals Act of 2013, which restricts any untrained person from administering drugs. So through this engagement, we moved to the second phase, and this was done in 2019-2020. This was implemented through USAID OFDA funding. And in this case, we involved the Livestock Emergency Guidelines and Standards, who had been commissioned by USAID to undertake an operational research on existing electronic voucher models. So the whole process involved redesigning the model in line with the Veterinary Professionals and Paraprofessionals Act, in line with the requirements, the stringent requirements in ascertaining drugs quality, and also ensuring there is restriction on the E-voucher for animal health services, and also restricting handling of drugs quality and more involvement on from the Department of Agriculture, Livestock and Fisheries. So if you can take some time to look at the structure on the right side, we had aggregators, in this case, Sida Africa Limited, and this was the head office who acts as both partially as manufacturers, as distributors, and partially as wholesalers, who supplied the drugs, looking at the black arrows, to the private veterinary pharmacies. These are agrovets that are in shops spread all over Marsabit County. We have about 8 of them in Marsabit. We were working with 4 in this particular process. And then the drugs find their ways to the communities through animal health service providers, who we, in this process, concerned, commissioned, and engaged animal health service providers who are graduates that were unemployed or underemployed, and according to the Veterinary Professionals and Paraprofessionals Act, could handle drugs. We also had a technical element where concern supported Sida. That Sida is a private company for those in Kenya, and I think for those who might be familiar with their work. And the whole idea of starting Sida was to try and meet the gap of private animal health service in northern Kenya, which includes Marsabit County. So it was a technical support for Sida to see that this is a possible niche market that has a huge demand, but there is no supply of animal health services, and you are a private sector actor. The other element was working with the county government that as much as we are supporting setup of this structure, it's the government's responsibility to ensure that the services and the quality of the drugs, as well as the quality of the services that were being provided, were in line with government regulations and in line with desired qualities. We also engaged the bank, in this case Equity Bank, considering the experience from 2017-2018, to create a wallet that could only be utilized in certain points of sale machines. So an animal health service provider will be given a normal ATM card, but the ATM card had 2 wallets. One is the regular wallet that anyone that is familiar with an ATM card, you can go and swipe in any point of sale machine or from any ATM vending machine. And the other one was a restricted wallet where we put in the money and it could only be transacted from points of sale machines that were given to 4 private veterinary pharmacists. So each animal health service provider had been allocated resources between $3,000 and $6,000 to access drugs and go deliver these drugs and the professional service to certain number of communities. So in this process, we targeted to reach around 64,000 animals from 3,000 beneficiaries, but the process was implemented in a period of 4 months, where we reached only 64,000 about 64,000 animals, and from 1,700 beneficiaries whose animals were sick at that particular period. Some of them were also non-beneficiaries, but pastoralists who were within the locations that we targeted. One of the things that we also included was we engaged a bigger number of partners, in this case Concern, which we are still driving the whole process because this was trying to model a working voucher system. We had the Department of Agriculture, Livestock and Fisheries, considering that there is the regulation, environment, service delivery is a responsibility of the county government. We had Equity Bank providing the point of sale machine, providing the special wallet ATM. Sida Africa Limited, in this case, this is the private veterinary service provider, from wholesaler to retailing at veterinary pharmacists. We had Meds Company to undertake random assay tests. This is where when we are ascertaining a certain number of drugs, for example, tylosin, the certificate of analysis for tylosin clearly indicates what components and what ingredients are constituted in that particular bottle. So we'll take sample bottles, and LEGS, the operational research team, will also take sample bottles from used and unused vials, take them to Meds Company to undertake an assay test to ascertain is the ingredients exactly matching what was provided by the manufacturer's certificate of analysis. And we had the animal health service providers. One of the things that was coming out so clearly, and we'll see that in a short while from the operation research findings, was that Concern's involvement was still significant for a private for a private animal health service delivery system, but we managed to reach a very large number of animals and provide better quality services compared to any attempt that we had done in the past and any other attempt that we are aware of on E-voucher system. So from this, the legs operation research, which was trying to find out what's the best model to use, came up with a number of observations. One of the observations was that the E-voucher model was an effective response tool during crisis, considering the speed of delivery, the scale of delivery, and the market system that was existent in Kenya. But the E-voucher model, as implemented, as shown in the diagram in the previous slide, was not market-based. It was largely concern-driven, and there was no clear sustainability. There was also low accessibility and high cost of services, which was the most limiting factors for poor pastoralists, because the whole idea of initiating the model was to showcase SIDAI, a model that if they implement, pastoralists can easily buy and pay for those services. But still, accessibility was low and the cost of services was still high. We also found there was a need for improved targeting of beneficiaries and adoption of cold chain technologies to assure quality. How do you distinguish who to provide smart subsidies to from a humanitarian angle and who to pay for these services? And how do you transport some of the drugs that require cold chain in a county that is about 70,000 square kilometers with limited electricity coverage? Then there was a need for capacity building, especially on business skills for the private veterinary pharmacists and the animal health service providers. How do they cost their services in such a manner that any pastoralist can afford to pay for those services, just like the way human health is provided? There was need for capacity building on regulation for veterinary pharmaceuticals. How do you make it cheaper than undertaking regular assay tests? For every assay test, it costs about $500. You can't do that on a so frequent basis. How do we ascertain that the standards were there? Because there were different restrictions from the Kenya Veterinary Board, from the VMD. Some of the recommendations that informed now the third phase was we needed to strengthen the private sector presence in the remote areas. The model works, but how do we get the private sector to be present more in the remote areas? The need for working through market-based systems and avoid contracting the animal health service providers or community animal health workers. Considering this operational research was conducted both for Kenya, Ethiopia, and Zimbabwe at the same time. So Ethiopia and Zimbabwe were working with community animal health workers. How do we involve the private veterinary pharmacies? These are the retailers from the start on the voucher design and redemption process. And how do we include operating costs for the e-voucher? Apart from the drugs cost, how do you include the service cost? How do you include the transport cost? How do you include the meals and accommodation cost for the service provider? And break it down per animal. The need for providing trainings to stakeholders on good drugs administration practices and business skills to animal health service providers, considering there was a very clear indication that their services were needed and there was a huge self-employment system. Finally, how do you standardize treatment protocols for community health workers? We worked with 8 animal health service providers. All of them were diploma holders in animal health technology, but not all of them were delivering the same level of services, which clearly indicated that our professionals still need to be supported to standardize the treatment protocols for community health workers. Based on these findings and recommendations, in 2020, we moved to the third phase, We moved to the third phase, which was SIDAI driven. Considering we had started working with the SIDAI agrovets in 2017 and involved SIDAI Nairobi head office in 2019-2020, we felt we could close the cycle by trying to enable SIDAI achieve what they were supposed to achieve in the first place. So the model is led by SIDAI. And that meant SIDAI committed to expand their presence. Their structure at the moment is SIDAI Nairobi, SIDAI regional offices, franchisees that are called the private veterinary pharmacists. But we had a gap from the private veterinary pharmacist, which is a stationary shop, to an animal health service provider that either uses a motorbike or a vehicle or on their feet to provide services where the livestock was. So there was that commitment. The need to cost the animal health service packages in such that for every disease, we cost it per livestock type per service. How much does it cost to treat PPR, for example, for one goat. How much does it cost to provide one service for one cow? How much does it provide to provide a treatment for one camel? So that we don't have that whole package where you pay for the entire vial, you pay for the entire transportation cost. And this has always been the deterrence for why we don't see private animal health service going to these remote areas. We also faced in such a manner that concern and the Department of Agriculture, Livestock and Fisheries roles were limited to compliance monitoring and subsidy to the poor pastoralist. Just like borrowing from food security interventions, where when there's a food insecurity crisis, you provide cash assistance targeting extremely poor and most vulnerable individuals who go and get their services where everyone else gets their services from the markets. So our role will be limited in terms of just providing the services, the subsidy, but ensuring that whatever we are supporting to subsidize is compliant to the requirements and regulations. Then there was a need to also start looking at expansion of competitive private animal health services where livestock are concentrated. Why only Sidai and there are other individual agrovets? How do we expand and make sure that this is a niche and anyone else gets the same capacity that we have been building Sidai Africa to have? Then to continue quality control and sensitization of pastoralists on drugs handling. This is one aspect of the Veterinary Professionals and Paraprofessionals Act of 2013, where we have seen it's forbidden and it's an offense, a criminal offense for someone who is not an animal health technologist or a veterinary surgeon to handle drugs. But because of lack of presence and lack of regulatory environment in the arid and semi-arid areas, we still see a lot of this. But we also saw from feedback from communities that were supported in the second phase that when the drugs were administered by professionals, the results were more effective and better than when they were administering by themselves. How do we create that sensitization for pastoralists to take the initiative of seeking these services from professionals? And in the third phase, we scaled up to 4 counties, that is Marsabit, from where we had started and piloted the whole process, to Turkana, Samburu, and Baringo, working with the Sidai systems. And we have also seen, especially around June, July, other donors that are being interested in the model. The national government through the June 2020 subsidy program for providing animal health services and other non-food items to agriculturalists and pastoralists using an E-voucher model. The World Bank also had shown an interest in working with the E-voucher model. So how do we scale up these lessons? And the whole reason of having this presentation was to share these experiences and lessons on how do we better these practices. So this is the stage where we are at the moment. The whole process is being driven by Sidai. We have managed to cost services per animal, where the services are at the moment ranging from between 20 shillings, which is about 20 cents dollars, to around 80 shillings, which is $0.8 for goat animal health services per goat, and approximately 100 shillings to 200 shillings, which is $1 to $2 for cattle and camels services. And the whole process is now being led by Sidai Africa Limited, where we anticipate by June next year, we'll be in a position where we can see how much of a success has it been and how many more pastoralists that are not part of our subsidy program actually access and utilize these services. So that was the major focus of the presentation. And I saw a number of people, I think, raising hands during the presentation. And back to you, Kun.
Thank you, Hassan. So yeah, so for those who are still interested in asking questions, please continue using the Q&A function. I think it's working quite well now. You can also always take the floor if you want to. So, but Hassan, let me quickly go through the 5 questions we already received. Normally, you can also see them through the Q&A option. So the first question is with respect to data security. How do you respect data security and anonymity for the participants using the e-card? Then the second question is about the LEX research. Is it available online? Has a business relationship between Sidai and the PVPs continued after the intervention? Another question about the difference in results between the countries where community animal health workers are allowed to work and Kenya. And then given that Kenya's veterinary law inhibits administration of drugs by non-professionals, yet government services are not reaching majority of the pastoralists, how can your efforts be sustained when your project ends? So more about the sustainability also of your project and its results. And then what is the target group regarding para-vets or who receive the E-voucher, and how are those people selected? Let's perhaps start already with these and then afterwards dive deeper into the others. So Hassan.
So thank you, Kun. Regarding the data security and anonymity for the participants, the e-voucher works like an ATM card, and essentially it has the same elements of security as a regular ATM card, where the information is between you, the provider or the user of that card, and the bank that's providing that card. So we were relying largely on the bank's confidentiality systems, and the only details that we were capturing for ourselves was the names and locations and a certain level of identity of the beneficiary and how much was being utilized. Regarding the second one, the research is available after this through Kun. If there is a mailing system, we can share that. But there is the process of creating the third edition of LEGS manual that I think will end in the first quarter of 2021. And these are two publications that will be part and parcel of the new LEGS, the new LEGS handbook. But you can share that, and they are available on the LEGS website.
And if I may say so, so we also have with CELEP a very good website focusing a lot on all of these publications and etc. related to pastoralism. And I think there was also a message shared in the CELEP Google group very recently on LEGS. So there are definitely entry points also within CELEP. Sorry.
Thank you, Kun. And the second part of the same question is that the PVPs, the private veterinary pharmacies, were actually franchisees of Sida. They were not Concern's partners. What was Concern's partners was the animal health service providers, who are now transitioned to be partners and part of the franchisee of Sida. So that relationship has now gone not in Concern's hands, but in Sida Africa's hands. In the different countries where the publications indicate that where the community animal health workers were present, the service was faster and more visible than where we had the animal health service providers, because it was really costly getting the professionals and not working with the community animal health providers. But when we share the findings of that result, I think it clearly indicates the difference of the different elements. But there was more professionalism where we had the animal health service providers and better drugs administration in terms of from a quality perspective. The question is, given that Kenya's veterinary law inhibits administration of drugs by non-professionals, how can your efforts be sustained when your project ends? The whole reason why in the third phase it's driven by Sida Africa is to ensure that this is a service that is regularly available, and in future, whenever there is a humanitarian need or whenever there is a massive disease outbreak, our role is just to provide subsidy for a service that is already existent for extremely poor pastoralists. And that's why we had been going from one phase to another, reducing our involvement and creating a substitute of concern, in this case, Sida Africa, which is a private company. And hopefully in the future element is to get competition for Sida to avoid possibilities of a monopoly developing. The target group of the para-vets, these were animal health technicians, people who had diploma. We gave them the ATM. Most of them we had a casual contract engagement, considering these were not staff, we could not employ them. And the reliability was that this wallet could only be accessed in certain point of sale machine, and you cannot even withdraw it from the Equity Bank ATM. So in the event anyone decided not to use that money, or fortunately all of it was used the way we expected it to be used, but in the event any one of them did not use it, we could easily retrieve our money through Equity Bank, considering the point of sale machine is largely restricted by the bank, and the card is not in the regular wallet, it's in a restricted wallet where you can only access it with one particular point of sale machine. If you had opportunity to start the e-wallet project again from scratch, what will you do different? The main difference will be getting more participants from the word go, getting the private animal health service providers in the discussion to understand why are they not providing these services, because we got that in the second phase, to get to understand. And it was a matter of no one trying to quantify what kind of market niche that was there available. And it was a massive market niche because there are almost 2.3 million animals in Marsabit alone. There is approximately animals worth $4.5 billion in northern Kenya. Most of these don't access private animal health services. And we have losses between 10 to 15% according to FCDC, the 10 ASAL counties. We have 10 to 15% losses as a result of lack of animal health services. So what we'll have done differently will be to engage the private animal health service providers earlier in the discussions to see how can you actually come and benefit from this particular market while providing a service that is much needed and creating an economically viable sector. How did you ensure that the drugs purchased with the e-vouchers were not resold to other agrovets, personnel, and solely for the project? This is where we engage the animal health service providers who were handling the drugs and they were administering it. But we created a system of checks where we had two recording systems, one done by the communities and one done by the private veterinary pharmacists. So we are trying to correlate with a 10% margin of error the amount of drugs that were administered as recorded by the community and the amount of drugs that were supplied by the veterinary pharmacist. But considering if you have like a 5 milliliter vial, someone might put 6 milliliters. So we are giving a 10% margin of error for discrepancies, but most of the discrepancy ended up being 2 to 3%. So that was the major way that we are trying to ensure that these drugs were not lost from when they left the veterinary pharmacist to when they were supposed to reach the animals in the community.
Thank you so much, Hassan, for these answers on all of these questions. Thank you also to the participants for asking so many questions. Meanwhile, I see another question popping up in the chat box, and I quote, so Hassan, given the fact that pastoralists are mobile, how does SEDAI's fixed point services cover vast areas like Marsabit County?
This is where in the third phase, we introduced a third layer for SEDAI, where SEDAI used to have the regional office in the national office in Nairobi, regional offices, 5 of them across the country, and veterinary pharmacies. These are the agrovet shops. So now they have enlisted a number of animal health service providers on motorbikes to move around with drugs. So it increased their service coverage, and it also provides them a new avenue and an extra avenue for moving their drugs and services.
Thank you. So Hassan,
more questions?
Yes, the questions are coming in very fast now.
I can respond directly. I can respond directly because I have opened the question and answer.
Please go ahead.
So, did the AHAS witness an increase of non-subsidized demand for professional treatment? We didn't, in the second phase, we didn't see that increase, but out of the 8 animal health service providers that we engaged, 2 of them are now working privately as a result of the experiences that they gained from this exercise. And the new one that we are now, the third phase that we are working with, we anticipate we are going to make it open that any person can buy the services at that subsidized cost, but for the extreme poor pastoralists, we are going to subsidize it for them. So the subsidy has 2 angles. One is to create a market and an enticement for SEDAI to invest in the low-level animal health services. That is the low-level reach, the grassroots reach. And secondly, to ensure that whatever we are providing from a private angle does not exclude the extreme poor pastoralists. Then from Regine, the 2 presentations we had today operate in a geographical area with a common border. Do you see an opportunity linking the 2 interventions?
Actually, that's a question also for Emmanuel. So I don't know, Emmanuel, I hope you're still around. If you could also answer that. So, but please, Hassan, you can go first.
Yeah, I think even for me, it was a learning opportunity, especially for the One Health approach. And I think this is an area where in Turkana, for example, where we are going to deliver the third phase borders with Karamoja area where Emmanuel presented about the One Health approach. And I think there's an opportunity to try and see what kind of cross-learning purposes can we have and how can we utilize this system to ride on either to introduce the whole environmental health and human health elements, because at the moment, these are 2 areas that as an organization concern we are focused on. And maybe for Emmanuel, probably utilizing the same structure to see how can a private animal health service delivery system. So I feel this could be an opportunity for us to create further discussions, because it's not something that we have already thought out of, but I think, and I really feel the whole reason why we have the webinars and we have the multiple series is to create that evolving partnerships and opportunities to learn and get to practice what's working best in one area and apply it in another area, because we are all there to serve the same communities and to reduce vulnerability.
Exactly. Emmanuel, would you like to react to this?
Yeah, I just wanted to say that I completely agree with Hassan. There are very many thematic areas that we can learn from each other. If we can, actually not if, we shall now continue conversation from here and see opportunities for collaboration. What is clear, for example, is that the Turkana pastoralists in dry season spend more than half of their time in Karamoja sub-region, especially those who are rearing cattle. Yes, so definitely there will be opportunities for linkages. Thank you.
Thank you. Thank you very much. Just perhaps also what I could highlight or add is that with VSF International, which is the international umbrella of all the VSFs, we developed on a framework on One Health, which is actually available on the website, vsfinternational.com, and parts of the presentation of Emmanuel were also inspired on that. So in case everyone, you want to know more about the One Health approach and VSF International's vision on that, please go to that website. Now, I think we've reached more or less the end. I don't see any more questions popping up either in the chat box or through the Q&A. Nobody's raising their hand either to take the floor. So I would like to thank first and foremost Hassan and Emmanuel for these interesting presentations. It was very good. I think we had a very nice webinar. Also, thank you, Cecilia, because nobody can see you, but you've also assisted a lot in organizing the webinar. Thank you also, Anthony, who's my colleague who's in charge of the technical aspects. And thank you all for joining. It was very interesting. So as I said in the beginning, this is actually part of a series of webinars. So the next edition is planned for the 12th of November. It will be hosted by IIED, and it will be on conflicts in pastoralist areas, with different presentations by IIED and also other actors, including also CELEP partner Karamoja Development Forum. So we'll continue also in the same region. So that's more or less it. Thank you so much. And I see actually 2 more questions. I know. If we can share the presentations, yes, actually we will. If you go to the CELEP website, there will be a summary coming up on the presentations and also the links and etc. Afterwards. So there will be a wrap up, and the webinar has also been recorded and will be made available through social media. Thank you so much. Have a nice rest of the day, and hopefully we'll see each other again on the 12th of November. Thank you. Bye.
Thank you so much, Kun, and thanks everyone.
Thank you.